Yeah.
Yeah. So good afternoon, everyone. So I'll be presenting on a homemade do-it-yourself aqueous sampling device for anterior chamber tap in endophthalmitis. So endophthalmitis can be post-operative, post-traumatic, endogenous.
Slides here, please. Slides, please. Can you put the slides on here, please?
So shall I start again? So good afternoon, everyone. I'll be presenting on a homemade do-it-yourself aqueous sampling device for anterior chamber tap in endophthalmitis. Endophthalmitis can be post-operative, post-traumatic, endogenous, or secondary to keratitis. Rapid diagnosis and appropriate treatment is required to save the eye from irreversible blindness. And accurate, appropriate, and adequate sampling is the key to precise microbiological diagnosis. So we can obtain various specimens which include vitreous taps, vitreous biopsy or vitrectomy fluid, which are more sensitive, but they have to be performed in the operation theater by a retina specialist, and a considerable time is lost before initiating the treatment, leading to further growth of organism inside the eye and cause worsening of the condition. Another specimen can be obtained is from the Aqueous tap, which can be done by a comprehensive ophthalmologist and can be done before referring him to a retina surgeon. The purpose of the study was to compare aqueous tap performed by novel aqueous sampling device, which we call AST, with conventional sampling method using 26 gauge needle mounted on a tuberculin syringe, which is CST group, to compare the sensitivity results of AST with vitreous biopsy. And the design is a randomized controlled clinical trial. So this is how it is being done. This is a tuberculin syringe being used for withdrawal of the aqueous, and the basic difficulty is again you have to use both the hands to hold the syringe, and an assistant sometimes is required just to hold the eye before taking this sample. Whereas the aqueous sampling device is a 2 mm syringe is cut, the phalanges are cut, and a rubber dropper is mounted on the top of the syringe. This is then you just press the rubber dropper and you can get the, while you release the rubber dropper, you just collect the sample inside this syringe, which can be then sent for sampling. So doing it on the live on the patient, you see, just we have inserted the syringe, and you can hold the globe with the other hand. So needle is then withdrawn and fluid is then sent for microbiology, and you see the sample is collected into the syringe. So 40 clinically diagnosed cases of endophthalmitis were divided equally in 2 groups. The group A was the conventional technique with aqueous tap using tuberculin syringe mounted, 26 gauge needle mounted on a tuberculin syringe. Group B was 20 cases with aqueous tap using this novel device. All samples were collected by ophthalmologists in operation theater under peribulbar anesthesia. Aqueous tap was followed by vitreous biopsy and injection of intravitreal vancomycin and ceftazidime. After collection, samples were sent to laboratory for immediate inoculation and gram stain. So positive results means organism was detected on either gram stain or culture, and result was also compared with the vitreous biopsy to rule out any false positives. So coming to the results, both the groups were equally divided into the cause of or the etiology of the endophthalmitis into post-operative, post-traumatic, and endogenous, but they were equally divided. The aqueous samples were sent in 20, both 20 in the CST group as well as 20 in the AST group. But the lab returned samples as not sufficient in 9 cases out of 20 in the CST group, and in 5 cases in the AST group, that is the novel device group. So samples processed ultimately was 11 in the group A and 15 in the group B. Positive result came in 3 patients in the group A and in 9 patients in the group B. Vitreous biopsy was sent in 20 cases in all the patients, and they were almost same. 15 were positive in group A and 14 were positive in group B. So according to these results, the accuracy of the ASD was came out to be around 86.7% as compared to the conventional technique, that is 63.7%. The sensitivity again was very high, 81.8% as compared to CST, which is 42.9%, and specificity, because there were no false negatives and false positives, it was 100% specific. The results were 100% specific, and moreover, in more patients we were able to collect the adequate amount of sample for processing. So the advantages include adequate sample is obtained, no need of an assistant. Sample can be obtained by comprehensive ophthalmologist. Sample can be taken without delay at the primary center. Positivity comparable to vitreous biopsy, and it can be prepared immediately, or these instrument can be pre-prepared and sterilized for later use. The limitations of the study are that it's a very small sample size and it's not a blind study, though it was a controlled study, but it's not blind study because the lab technician was there to collect the sample inside the operation theater. So conclusion, though vitreous is the best source for obtaining a specimen for culture or smear examination, this novel device is easy to use, and an aqueous sample is obtained using it before giving an intravitreal antibiotic by primary ophthalmologist, which gives adequate positive results. This gives adequate positive results, thus avoiding delay in treatment and worsening of the disease before referring the patient to the retina specialist. Thank you. Yeah. Yes. This is a safety valve which, if you need to stop the sample collection or just a sudden spurt, you throw. Yeah, you get them in the market. Yeah, yes, they are available. These can be ETO'd or this can be plasma also. Done plasma also. Yes. Yeah, you make the whole thing and then you can sterilize them. Yes.
Did you find it difficult when you have a thick fibrinous AC reaction? Because when you showed in the picture, one was fairly clear and the other was very...
Yeah, definitely you have to place in that area where the fibrin is less or the hypopyon is less dense so that you get an adequate sample. Otherwise, the fibrin is just going to clog into the needle. That will happen in both the cases.
That was a little disconcerting, because was there a bias because the examiner viewed those things?
I can't say, but we obtained the samples and he had collected those. They had been cultured, and the positive results came from that only. Yeah, I said that it is not a completely blind study. There could be a bias in there, but most of the studies, only when the culture became positive or the gram stain showed something, then they were labeled as positive.
So both these techniques were done in a peribulbar anesthesia. So if you would have to do it one with your technique or innovation under topical, do you think it would be a useful?
It will be better because only then you can hold the eye and you can take the sample. Otherwise, if you are doing with a tuberculin syringe, you have to use both the hands to get the sample, and then assistant has to hold the eye.
Another thing is that this rubber stopper which you have, even if you remove the piston from the syringe and make it an open thing and just use your finger to open and close it, but I think that is a good enough tool. Means what additional advantage does it offer to a normal piston?
So when you are going to inoculate the sample again, you will need some pressure to pour that fluid into the sample. And secondly, again, you can definitely control, you can have more suction on this. With this, you can actually create a vacuum and suck easily. So you see, if you put it just inside the fluid, the needle, it won't suck, right?
So you want to do an active suction?
Active suction, yes.
Basically for anterior segment surgeons, like
basically for
and it has similar sensitivity and specificity as to the vitreous sample.
Yeah, you can,
but not
you have
as good as vitreous.
Yes, it is not as good.
Because aqueous sample itself is not considered to be
it is not as sensitive as the vitreous.
As sensitive.